Welcome to part two of our sex and gender lecture. We'll pick up where we left off with the sexual disorders. Um, Erectile disorder, which is the inability to actually get an erection for a male. Our treatments are sensate focus, where there's a non-demand pleasuring where you're naked with your partner, but you don't touch genitals or any of the sexual type of areas. You just kind of get used to being sensual. And the big focus with this is focusing on the sensual aspects of your partner's body that are pleasurable, but it's non-demand. And so one of the things that you tell the patient is, if you might get an erection during this, you might not, but that's not the focus. And there's something called spectatoring. With sensate focus, we're trying to reduce what we call spectatoring, which is when you're thinking to yourself, it's not going to happen, or it does happen, and it's a big victory, where you get an erection and you can have sex. And so in the mind of men, you start thinking, it's either a success or a failure, and then there's this big pressure on you. The idea behind sensate focus is that you learn to enjoy your partner's body without that demand, without thinking it's either going to be a win or a loss. And so that's the big thing with sensate focus exercises. Then some other treatments for erectile disorders. Sometimes men, when they get older, they get really low testosterone. It's normal for testosterone to dip, but if you get it tested and it's very low, that could be a contributing factor. There's a supplement you can buy called Yohimbe, which is kind of a natural stimulant that works for some people. Then we have our erectile dysfunction meds that are very famous and on the med list that I have you learn. And last, the most dramatic thing is penile implantation, where the spongy tissue that fills with blood is replaced or supported with an implant. So other treatment modalities, female and male orgasmic disorder, so the same with the sensate focus, directed masturbation training, it's usually for females. And with females there's some women that have never actually been able to have an orgasm. What we do with directed masturbation training is we direct them to touch themselves when they're alone, not with their partner, because they'll be self-conscious, and just learn your body, learn what feels good. And part of that with females is usually trying to get them comfortable with the idea of using a marital aid, a vibrator, or sometimes women have used those flexible shower heads where you can take it down and change the settings on the shower head and use that to masturbate. But the big one is really vibrators. And then with early ejaculation, usually called premature ejaculation in the past, we have the sensate focus exercises again, where you're being sensual with your partner and just kind of ignoring if you're and get used to being around them, so that it's for the person with early ejaculation, they need to not be so stimulated. Learn to be in the sensual situation. One of the big things with early ejaculation that's famous is when the male is having sex, to try to think about. I think the cliche was think about baseball, or something to distract you, basically. one of my coworkers said he thinks about his grandma naked to slow down so he doesn't have he doesn't ejaculate too soon. Um, th those that's not really what we want to teach when we're helping somebody with early ejaculation. Because what you really want to do is be more focused on your sensations so that you know when to back off when you're getting too close. So it's not really distract yourself. It's really actually pay more attention and just learn to slow down. Um, it's good that you're excited uh, during your sexual encounter, but if you come too fast, if you ejaculate too fast, your partner hasn't had a chance to enjoy the sexual response system for males and females is different. It it's the same. The human sexual response is the same, those same stages, but for females they go through a lot slower. And so for males, you need to slow down. So there's something called the squeeze technique, and it's usually the partner, especially if it's missionary, it's easy to reach, and you just put a gentle squeeze around the base of the penis to help, kind of slow down the blood flow and help them not ejaculate too soon. So that's just kind of a gentle squeeze at the base where it's not sensitive. We have what we call delayed ejaculation. This would be a nursing diagnosis. Delayed ejaculation used to be called retarded ejaculation, but nobody wanted to think of their penis as retarded, so they renamed it delayed ejaculation. And so one of the big causes, especially in older men, is having been circumcised. The foreskin, one of the things it functions as is besides just kind of protecting the penis, is it keeps it sensitive. So what happens with when you're circumcised, as you get older, the skin that is meant to be inside, it's like outside all the time, and it gets keratinized and it gets thicker. And so there's some treatments for that where you either kind of tug your penis at the base. There's usually some foreskin that at the base of your penis that if you tug on it enough or use one of these there's a device you can buy that you wear and it kind of pulls on it all day gently. Sounds very uncomfortable, but it some people say, and some people have promote that you can actually regrow kind of stretch that foreskin skin enough where you actually can restore your foreskin, and eventually it'll make your penis more sensitive because it won't be out, it'll be inside like it was meant to be. And then there's also delayed ejaculation that can be related to diabetes, where with the way that the nerve endings get covered, where they're make your feet numb and mess with your eye nerves and give you eye problems. Diabetes also makes your penis less sensitive because of the way that the blood sugar, the way that it makes nerves less sensitive. All right, so with genital pelvic pain penetration disorder, so the first thing we want to do is refer them to a gynecologist. Make sure there's not like a physical thing going on. So then we educate the woman and her partner. we our big treatment for this is if you remember systematic desensitization, where we introduce things slowly. You probably remember that from the anxiety disorders lecture with the example of the people that are phobic with spiders. It's just the same with dilators of graduated sizes. Um, they're just a small thing. It starts out as a small thing that you insert in your vagina, and you want to do it in a sensual way where it's sexual. It's not like a medical thing. Um, and then you can use that. The sizes get bigger as you get more used to it, and you can accommodate it. Sometimes they give this to women after childbirth to help kind of open up the vagina again after the trauma of having a baby. Um, and see, and then treat any relationship problems. One of the things that I'll tell you, when I did marriage counseling, almost every time I got referred a couple that had some kind of sex therapy issue, there was a lot of, you know, things are more complicated than that in most cases. Um, there would be resentment issues that really were the base. You know, they get referred to me for sex therapy type of things in the marriage counseling, but really it turned out there would be a lot of anger and resentment over other parts of the relationship, and that would leak over into the sexual part of the relationship. So dealing with that first, and dealing with any kind of resentment that's going on. Um, Also with this disorder, this it used to, you know, the old name for this disorder, the really old name was called quiet vagina, which is a kind of a funny name. But you know, sometimes with this disorder, also the person has been raped in the past, and so you know their body's kind of shut down, and it's like a protective mechanism. And so we want to work on any kind of, you know, psychological stuff that's going on with this as well. But sometimes it really is just the body having a reaction. So gender dysphoria, gender identity, the sense of knowing what gender you are, you know, historically it it was known by like age 5 or 6, children would know what gender they are. Um, there's something going on in the culture where it's it's almost encouraged in the culture right now to reevaluate your gender when you hit puberty, and even later in some cases. And so there's that's something we'll talk about in the future slides, how to deal with that. But you know, it's obvious. I'll just go into it here, what's on the slide. When your biological assigned gender is different than the one that the person feels they are and the experience. And there's distress. There's the critical element is clinically significant distress associated with the condition. They're not feeling good about it. And I know I work on an adolescent psychiatric unit, and you know I see a lot. It seems like with the adolescents, this is something that it's almost encouraged among the peers to have a gender issue. Um, yeah, so this is a complicated issue in society right now. So the prevalence is estimated about 1 in 30,000 men, 1 in 100,000 women. However, I can tell you from what I see in my little unit in Berkeley, there's a lot of females to male transgender going on right now as well. Um, we've always had this in psychology where there would be people that believe they were a different gender. Usually they would know that very young, like age 5 or 6, when or even 4, where a child gets an identity with whatever gender they are. But like I said, in our culture right now, there's a reevaluation of your gender in adolescence. So gender dysphoria in children. Um, yeah, so repeatedly stating this, the preference upon dressing and clothing the opposite gender, um, persistent fantasies of being the opposite gender, playing the games with the other. So basically, in the latency age, the age where, you know, from like age 6 to 12, you remember in Freud's psychosexual stages, they what's normal is for children, they usually play with their same gender. And so the gender dysphoria, the children want to play with the gender that they feel they are on the inside, and so that's why you'll see, girls wanting to play with boys or boys wanting to play with girls. Historically, we would call the girls tomboys, or the boys, it was a derogatory term, but they would be called like sissies, that kind of thing. Um, but that's what you would see is they want to be with that gender um, from age 6 to 12. Some of our treatment goals, um, trying to help them find acceptance, any mental health concerns, and what used to be the norm was to try to get them to not be transgender, to try to get them to have a therapist that's the gender that they're assigned and put pressure on them not to do this. But it was found that made kids more suicidal and more depressed. And the therapy culture now has it where we support their effort to live as a gender in which they feel more comfortable, let them explore, and and not try to guide them back to the assigned gender. So treatment should be a personal choice, and then they have all of these issues. It might be one of the reasons why I see them a lot on the adolescent psych unit. So they don't feel comfortable wearing clothes of their assigned gender. They might find their own genitals repugnant. They might, which is another word for gross. Um, they might want the hormonal and surgical gender reassignment. Generally, we don't do gender reassignment with children or young adolescents. Usually, that's something older that they do. But we can do the hormone therapy. The big thing with hormones is the hormone blockers when they're adolescents, so that they can work things out before their body starts making changes. I know this can be controversial because people will say, "Oh, you shouldn't mess with a child's hormones," but if you don't block those hormones, the secondary sexual characteristics will develop, and they'll have a hard time, appearing as the gender that they feel that they truly are. Um, they can in the later stages of adolescence. I have seen them a lot where they are getting hormones of the gender that they want, so that they'll develop the secondary sexual characteristics of the gender that they want to be, that they feel they truly are. Um, One of our problems that came out recently, one of the big doctors that does the surgery of the genitalia, what we call informally bottom surgery, they came out and said that the person that has bottom surgery almost always will have trouble having an orgasm for the rest of their life. And so there's a thought in the community now that maybe transgender patients should just accept the genitalia they were born with and just live in the gender that they feel they are, but still leave the genitals the way they the original packaging. Um, Treatment issues, so they'll seek therapy to learn to cope with their sexual identity. Um, Sometimes the therapy, there's a desire that we want them to really be sure before we start doing hormones and surgeries. And so right now the thing is to live in the role of the desired gender for a year. All right, so moving on to homosexuality. So these are some basic definitions. I'm not sure why we need a different name for females that are gay, but lesbianism. So in the gay community, sexually transmitted diseases, particularly HIV, um, everybody knows, most people know that HIV is the way it's transmitted in people mostly is through unprotected anal sex, because when you have anal sex, even if you're trying to be gentle, there's usually little tears in the anus, and so the that's how the blood mix with semen. that's how it gets transferred very easily. Um, the other big way is IV drug use, where people are sharing needles. And so anyway, some other special concerns coming out if you're in a society or your family, they don't accept being gay very well. This can be a significant risk factor for suicide. And not that long ago, I guess it was 20 years ago, gay marriage was a big thing in the culture. Actually, helped the president get reelected, you know, and on a stand at being against gay marriage. But that seems to have resolved in our culture as it's much more accepted that there's really no reason why gay people shouldn't be allowed to get married. All right, other variations, bisexuality. This is where the client engages in activity with members of both genders, and it's considered more common than exclusive homosexuality. We'll talk about the Kinsey scale on the next slide. Um, Pansexual, where the person is open. If you hear that term, it just means they're bisexual and they're open to transgender people. Also, Pan was like a god of sex. There's actually a little tiny statue that my wife bought of him that's on in my cabinet. And he's a guy. He's like playing a flute, and he has a very big penis. I don't know more about that. You can Google Pan if you want. Okay, so this is the Kinsey scale, um, famous by the Kinsey um, sex researchers, and it kind of shows there's on the extreme left here, there's the 0 on the Kinsey scale where the person is exclusively heterosexual. And you see the other extreme, number 6, where the person is exclusively homosexual. And you can see here all the numbers in between where everybody there is a little bit bisexual. And so this also matches with what Sigmund Freud said. Which was very controversial in the years that he lived. He said that all people were inherently bisexual. All right, so there's an explanation of the numbers there. So there's not a lot of research done on bisexuality. And like I said, Freud believed that all humans are inherently bisexual, which is a very controversial thing to say during the years that he lived. Um, Still controversial now, I believe, too, for some people. Um, and then your sexual identity, your sexual orientation may continue to evolve throughout your lifetime. And I have family members where they're exclusively seemingly heterosexual, and then they met a person and had a homosexual relationship of several years with that person, and then now they're back to being in a heterosexual marriage. So those things they evolve throughout their life with a lot of people. All right, so some test questions. Which of the following are typical behaviors observed in clients with frauduristic disorder? A, the sexual focus is on non-living objects or parts of the body. The feet seem to be a popular one that are not considered erotic. B, exposure of one's genital to an unsuspecting stranger. C, observation of an unsuspecting person who's naked. And D, touching and rubbing against a non-consenting person. And so if you want to pause the recording to think about this, go ahead. All right, the answer is D, touching and rubbing against a non-consenting person. Number 2, a nursing instructor is teaching a class about normal human sexuality. Which of the following information should be included? A, gender identity only develops during adolescence. B, sexual drives remain consistent throughout the lifespan. C, many medications can impact sexual functioning. D, the elderly have little interest in sexual activity. So again, pause the recording if you want to try to guess. So this is one of those where I think probably most people know that that A is not correct, B is not correct, that our sex drives don't remain consistent. We have times in our life, the example was that for a male, like our sex drive is super high when we're young, especially age 16 to 26 or so, and then still high but less so, and then can goes down a little. It's still there at somebody my age, but it's not as intense, and I'm not as distracted by it as I was when I was young. Um, yeah, the correct answer here is C. Many medications can impact sexual functioning. And so what we mean by that are the blood pressure meds, things like that can interfere with your ability to maintain an erection um, and have an orgasm. Okay, looking at our learning objectives, what are some of the normal sexual developments a person should accomplish from birth through age 12? Historically, by age 2 or 2.5, children know their gender, but like I said, in the last 10 years, there's 10 or 15 years, there's been a shift in the culture where it's acceptable to revisit that, especially during puberty and throughout their life. Age 4 or 5, when they're in the Freud's psychosexual stage of the phallic stage, though it's totally normal to engage in heterosexual exploratory sex play. For an example, playing doctor, that kind of thing, where you're exploring the other person's body, that's normal at that age. And then then they have the latency age, which the sexuality kind of goes underground a little bit, not totally, but a little bit, mostly. Um, and then in late childhood and pre-adolescence, they usually kind of play with their own. All right, and then age 10 to 12, they start getting interested in the gender that they're going to be interested in sexually, and kind of work out their sexual orientation, dealing with these. So number two, the things facing adolescence, dealing with powerful sexual feelings, what kind of sexual behavior they're going to engage in. There's a lot of pressure on teenage girls to be more sexual than they're comfortable with at a young age. Um, how to recognize love. There's a lot of, let's see, how do I phrase this politically correctly? Sometimes young girls, they start getting attention for their body changes, and they don't realize they what they really want is love, but they get a lot of attention for the sexual stuff, and so sometimes they need guidance on how to manage that and not not have boys think they're more interested in sex than they really are, when they really are more interested in having a relationship. So that's part of what I mean by recognizing love. And preventing unwanted pregnancy. Pregnancy can, one of our things with adolescence is, we haven't really developed responsibility yet. And yet our sexual feelings are much stronger than our ability to understand how bad long long-term decisions, when you get pregnant and have a baby when you're a teenager, it really takes your life off course and makes it very difficult to be a high achiever in your life. It's not impossible, but it does create a very big obstacle if you have a teenage pregnancy. All right, and then young adulthood and middle age. So young adulthood, people usually try to find a marital partner. It's normal to try to build a life, build a family when you're young. And then other one of the things about human beings is we're basically we're monogamous, where we have one partner, but still we're sexual, and there's other people around, and some people engage in extramarital sex, and it gets that's part of what you have to work out, is not basically not doing that that because it destroys your relationship. In most cases, it significantly wounds it, and it takes it off in a direction that you might not want. But that's part of our human nature. All right, so number four, the eight paraphilic disorders, and a definition of each. And usually the reason people seek treatment is they're forced to seek treatment. So our paraphilic disorders, we have exhibitionistic disorder. This is a person that likes to flash other people their body, usually a man that does that. Fetishistic disorder, where they're focused on something like feet or shoes or undergarments or something like that, and they can that can get off in a direction that gets them in trouble. Frauderistic disorder, where they want to rub up against people. Usually, the famous one is like on buses or trains, where when it's very crowded and people are jammed in, um, they'll try to take advantage of that and touch people, pretending like it's an accident, and that can be that get them arrested and get in the legal system for that. We have pedophilic disorder. These are people that are sexually attracted to children, and so this is something that is very disturbing in society when this comes out. A big problem with some religions, that people will be attracted to this, and they'll take advantage of vulnerable people in that situation. Then we have the next one, sexual masochism disorder, where they get sexually excited when they're feeling pain. And then sexual sadism disorder, kind of the opposite of that, where they need to be giving someone pain to get sexually excited. Hopefully those two types of people find each other. Then we have transvestic disorder. This is somebody that gets sexually excited getting dressed in the clothes of the opposite gender, and that's usually it's usually a man that gets sexually excited dressing like a woman, but I guess it's possible the other way around also. Um, these are not transgender people. They're not trying to be that gender. They're just sexually excited by wearing the clothes of that gender. And then voyeuristic disorder. These are they call them peeping toms. These are people that'll go around and try to watch into your windows, or put like a little surveillance camera in your room where you make love, and they'll peek in your window, and what they really get excited about is seeing somebody in their privacy, seeing something they're not supposed to see. They're not. These people don't go to nude beaches where everybody's walking around naked and just look at everybody. They try to see something they want to see you where you don't want to be seen, like in your private moments when you're undressing. All right, so number 7, some biological factors that might predispose someone to an orgasmic disorder. Um, so those, let's see, I missed number 5 here. Describe each phase of the sexual response cycle. So we have phase 1, desire, phase 2, excitement, phase 3, orgasm, phase 4, resolution. So remember, in those four phases, um, those there's a problem that can happen in each one. So with desire, that would be somebody that doesn't have any sexual desire, and excitement could be where you have the desire, but just give an example for men, they have the desire, but they can't get an erection. Um, the same for some of the female disorders, where they have the desire, but they don't get the lubrication that makes sex possible. And then we have orgasm, where in males, it can come too fast and be premature ejaculation or early ejaculation, I guess is the new term. And we also have the opposite of early ejaculation, delayed ejaculation, formerly known as retarded ejaculation, where the person has, the man has trouble reaching orgasm. And so we have we don't, in women, we don't really have a premature orgasm type of problem, but we have a problem where a lot of women have trouble reaching orgasm. And I'm not sure if I mentioned it on the slide, but our big treatment for that is usually getting them comfortable using a vibrator, to be to be very concise about it, getting over any feelings about it being weird, and learning how to have an orgasm in whatever way possible, and accepting it. If they need a vibrator, they can incorporate that into their lovemaking as part of, just part of it. There's no shame in needing to use a vibrator to reach orgasm. Okay, our last slide here with the final learning objectives. What are some psychosocial factors that may predispose someone to a sexual dysfunction? Um, it's not a very specific learning objective. I'm sorry about that. Um, just looking at some of the things that might predispose someone to a sexual dysfunction. Some of the big ones, unfortunately, are selective serotonin reuptake inhibitors, our most famous psychiatric med for people that have depression or anxiety. Um, they seem to hit us in our ability to have an orgasm. So, and also sexual desire for some people. And so those are some of the factors. Some of the psychosocial factors might be somebody that's had a history of sexual trauma, somebody that's in a relationship where there's a lot of resentment, um, somebody that has serious depression, something like that, or obsessive compulsive disorder. It makes it very hard to be sexual because if you're worried about everything being in order and clean and everything, um, most of the time sex is it's a little messy and it's a little disordered, and that's some of the stuff that's good about it for most people. um, some of the treatment modalities for the different sexual disorders. So we talked about, well, for erectile dysfunction for men, the meds really revolutionized. Um, when Viagra came out, it was much more effective than all of our behavior therapy type of treatments. But we still have those as well. We have the sensate focus is our big one for a lot of these. Just kind of getting in touch with being sexual without the demands of needing to reach orgasm. What we call spectatoring, where you're judging yourself. You're thinking, oh, is it happening? Is it not happening? Is it going to be a win or it's going to be a lose? We don't want that. Then we talked about the the disorder with the genital pain, where women have pain when they're see what it's called, genital pelvic pain penetration disorder. The treatment for that, like I said, a lot of times the problems are resentment in a relationship, but the actual physical treatments are those dilators that are graduated sizes, start very small. That would be termed by as a form of systematic desensitization. Um, those dilators that start small and they get larger until the person's body can tolerate sex. And then with that kind of disorder, we also want to make sure they haven't had sexual trauma. If they have, we want to get them therapy for that and resolve some of those issues. We want them to see a gynecologist first to make sure there's nothing physical going on. Um, okay, and then let's see, what are some other treatment modalities um, for early ejaculation? Like I said, the person needs to be more in touch with their feelings, not less. The cliche of thinking about baseball so you don't reach orgasm too soon. Um, that's like a distraction type of thing, and that's something in the culture that you'll hear people talk about. But treatment professionals, we want you to be more in touch with your feelings and more present, so that you know to back off when you feel like you're getting close to ejaculating too soon. All right, so number 10, gender dysphoria. This is clinically significant distress related to your gender. And so yes, let's see, the big things there: not being comfortable in your assigned gender, the gender that you were born to, and wanting to be, either I don't want to say the opposite gender, because there's so many different ways to see your gender. There's non-binary, where you don't want to be seen as one or the other. There's gender fluid, where you kind of go between the different genders, and so you don't want to be labeled as one gender. And number 11, some of the treatment issues for children. Remember, if they're in a culture where this isn't accepted, they can be suicidal, even at a very young age. Um, find their genitals repugnant. Number 12, some of the treatment issues. Hormone blockers for adolescents, that they can buy a little time to figure things out before they commit to letting their body develop secondary sexual characteristics. And with adults, also hormone therapy of the gender that they feel they are, so they develop those characteristics. And making decisions about different surgeries if they want to make surgical alterations to be the gender, appear as the gender that they feel that they are. Then number 13, some of the challenges when coming out as homosexual or bisexual. Are people going to accept them? This can be a reason. I've had adolescents come in the hospital just for this, because they were gay and they didn't feel their family was going to accept it, and it makes them feel suicidal. It's really important with your kids that they know that you're going to accept them regardless of whatever happens, whatever they feel they are, that you're going to accept them no matter what. They really need that kind of security. And if they don't have that, then if they're one of these and they feel like they're going to be rejected, it's very easy for them to be seriously suicidal. Then 14, there's a scale called the Kinsey scale. This was a sex researcher in the 70s and late 60s, where he has a scale where basically what he's saying here is most people are at least a little bit bisexual. And so he has a scale where it starts with 0, where people are totally heterosexual, to 6, where people are totally exclusively homosexual. And then most of those numbers are in between. And one of the things to remember is people can move around on this scale throughout their lifetime. All right, so that is the conclusion of our lecture on human sexuality, sexual disorders, and gender. I hope you enjoyed it.